Hi there, my name is Arsalan Zamir. I'm a GP with an interest in sport and exercise medicine. Today I'll be talking you through a knee joint examination with the consent of our kind volunteer. Thank you very much indeed. Now before we delve into the knee joint examination itself, we need to make sure that we've taken a prior background history to give us some adequate information that will guide us through the examination of the knee joint itself and make us focus in on particular areas, specifically in terms of signs and symptoms. Now, the first thing to do is to just make an inspection of the patient. So you can just stand with feet together for us, please. So we're looking to see whether there's any atrophy of the muscles, general alignment, any rotation at the knee joint itself. Also honing on, just if you spread the feet a little bit, just looking to see whether there's any difficulty with the arch of the feet, which may impact on the knee joint itself. Any swellings that might be apparent, any bruisings or scars. Next aspect we want to try and assess is the gait. So we're going to get the patient just to walk up to the room and back to the end, just looking for symmetry of the gait. Any difficulty there at all? You can just hold that there, pause for a second. That can sometimes just pick up any difficulties in the knee joint or any other areas in asymmetry. If you can get up onto tiptoes now, please. Walk up to the end of the room, please. And again, we're looking to see whether there's any difficulty there. Back on heels. Yeah, if you walk back on the heels. So the heel walking and the tiptoe walking can give us an idea if there's any neuromuscular problems. And most neuromuscular problems in the lower limbs we can screen out in this fashion. We're going to move on to core stability now. Core stability, very, very important aspect with relation to the knee joint itself, because poor core stability can impact on the knee joint itself and vice versa. So with core stability, a good screening tool that we can use is the one-leg squat. So if you stand on one leg, please, and just squat down for us. Excellent. Back up again. And the other leg. Squat down, back up again. So that tells us there's reasonable core stability there. It will be difficult for him to undertake that if he had a poor core stability. We're looking to see if there's any differential in height of the pelvis there in the hip area, and also if there's any rotation of the hip and knee joint itself. That might give us a clue as to any problems there. Next thing we're going to do is get the patient onto the couch and screen for any other confounding problems in the first place. So the first thing we're going to do is check for a neurovascular assessment. So if you could kindly just wiggle your toes for me, please. Excellent. So I'm going to touch down your leg and just tell me if the sensations are both the same size. Okay. Is that same? Normal. Excellent. And again. Brilliant. Just checking the refill. Fusion of the feet, checking the pulses, dorsalis pedis, and posterior tibial. So it's a well perfused, warm set of feet we've got here. Okay, now one leg at a time. If you could please raise your leg right up to the ceiling and back down again. Any discomfort there? Any pain, tingling down the leg at all? No back pain. Good. And the left side now, straight up again. As far as you can go. Brilliant. So good straight leg raise, back down again. Any back pain? No. Pain down the leg or tingling down the leg? No. Brilliant. So that gives us an idea there's neurovascularly no confounding issue that's apparent at the moment. Okay, check the hip joint now. So, do you have any pain at the hip joint at all? No. So let's just flex the hip knee. Up to internal rotation. External rotation. Any discomfort there at all? No. Full flexion of the hip joint. And then extension to a reasonable degree. Any discomfort there at all? Now, moving on from the hip, we're going to focus in now on the knee and the surrounding structures. So inspecting specifically the muscle areas, the quadriceps bulk, and making sure that that's the same on both sides. We're going to move down to the quadriceps tendon. Any discomfort there at all? Through the patella, down to the patella tendon, any discomfort there at all? We've got tibial tubercle, which could be problematic in Osgood-Schlatter disease. And then we've got the lateral hamstring tendons, and the medial aspect of the hamstring tendons as well, no discomfort there. We've got the medial collateral ligament, the medial joint line, and then we've got the lateral collateral ligament and the lateral joint line. Any tendons there at all? Okay. Now, we're going to focus in particularly onto the patella itself, which may have a patellar effusion, and that might present because of a patellar injury, such as a fracture or dislocation, an ACL injury, or a meniscal injury. A good way to check for patellar effusion is just to milk the suprapatellar pouch and then just to ballot the patella just to see whether it bounces within that fluid at all. The other thing we can check for is apprehension of the patella. So most patellar dislocations, 95% occur laterally. So if we actually distract, just relax there, distract the patella laterally, any discomfort there at all? And there's no apprehension there at all either. Brilliant. We're now going to move on to the range of movement of the knee joint. So actual movement, we're going to start with flexion. So a good degree of flexion just there. And extension, just see with any hyperextension. If you bend the knee for us, and if you just push me away with your leg, so that's quadriceps firing, and pull back, that's hamstrings. And then if you just upwards with your feet, so that's gastrocnemius, backwards, that's anterior tibialis. Excellent. Now we're going to move on to the ligaments. So the first set of ligaments that we're going to look at are the cruciate ligaments. Anterior cruciate ligament, Lachman's test is the most sensitive test to pick up an anterior cruciate ligament issue. Now the way to do that is just bend the knee slightly, just relax the hip for us. Excellent. Bring our hand up, and we're looking for anterior posterior distraction there, laxity. The other thing that we can do to check for an ACL tear is to use the most specific test, which is the pivot shift test. Pivot shift test, we've got the knee in extension. I'm just going to rotate at the tibia, put a hand on the knee joint itself, and just ask the patient if you feel any clunk or pain when I do this, okay? Excellent, so there's no pain or clunking there, okay? Now, on the converse, we're going to check for the PCL, the posterior cruciate ligament, and the easiest way to do that is with a posterior draw test. So I'm just going to bend the knee for us, and we're just going to put some anteroposterior distraction there, and there's no sagging there at all. Brilliant. Next set of ligaments are going to be the collateral ligaments. So in extension, we can put some varus force to see if there's any lateral collateral laxity, and valgus force to see if there's any medial collateral laxity. And then similarly, in 30 degrees flexion, lateral collateral with a varus force, medial collateral with a valgus force. Brilliant. Now, lateral collateral ligament can also be implicated in a posterolateral compartment issue at the knee joint itself. And a simple way to just screen for that is if you just relax your legs on the couch for us, just stay nice and relaxed for us, nice and relaxed, and just lift up, looking for is any sag at the posterolateral area, and there's none there. That's brilliant. Now, the final set of examination is going to focus in on the menisci. Now, with the menisci, the most popular test is the McMurray's. Before we hone in on that itself, let's check the joint line to see if there's any tenderness there at all. Any tenderness there at all? No. With McMurray's, in a supine position, hyperflex the knee, just rotate. So first we'll check for lateral joint line, and just looking for any discomfort, any clicking. And then similarly, repeating that, try and just catch the meniscus if there's a meniscal injury, and just extending the knee. Any pain or discomfort there at all? No. Excellent, good. Now, final aspect of the knee joint examination is going to be a standing McMurray's. Can you just stand up for us, please? Okay, just step on a little bit. Charlie Chaplin position for us. So feet wide out. Okay. And I'm going to just put my hand on the joint lines. I'm going to use the body weight to check for a McMurray's. So now if you just bend the knee for us. Excellent. Brilliant. Back up again. Any discomfort there at all? No. Now we're going to invert the toes, so pointing towards each other. Just 1 second. I'm going to repeat that again. I'm going to repeat that again with my hand on the knee. Just repeat that again. Back down again. And back up again. Any discomfort there at all? No. Brilliant. So that concludes our examination of the knee joint, and what we want to do is ensure that actually both sides are compared to make sure that we can pick up any asymmetry or abnormality on the differential. That concludes the knee joint examination. Thank you very much indeed.